It's a great pleasure to be able to talk to you today about the impact of COVID-19 on Black, Asian and minority ethnic groups. I'm currently working with the ECDC and others to explore some of these data sets in more detail that are emerging from Europe and globally on this topic. So as many of you will be aware, there's mounting evidence that the current pandemic is having a disproportionate impact on ethnic minorities and migrants, both in terms of direct impacts, higher risk of adverse COVID-19 outcomes, overrepresentation in cases and hospital admissions, and ethnic minorities and migrants being overrepresented in deaths in data sets in the US, Canada, and European countries. Furthermore, globally, we've seen a substantial indirect impact on migrants and other marginalised groups in terms of restrictions on movement, socioeconomic impacts. And the clinical data sets we have in Europe are and the US focus very much on this broad group, diverse group that we call ethnic minorities. In the UK, we refer to this group as Black, Asian and minority groups, or BAME communities. And within this group are an important subset of migrants, specifically people who've moved to another country to work, to perhaps claim asylum, or they could be undocumented migrants. And these populations, we know, have quite unique health and social needs in some instances. I'm sure many of you will understand barriers to healthcare, language barriers, migrants not being entitled to mainstream health services. And it's currently not clear in the data sets that we have what the clinical impact of COVID-19 has been on migrants specifically. In countries like Singapore, for example, where you have thousands of low-skilled labour migrants from Bangladesh and India, the disparities with COVID-19 are quite stark. There are very few community cases in places like Singapore, but there are thousands of cases in the labour migrant population. Often they're being restricted from leaving these migrant compounds and living in very poor conditions. This image at the bottom is from the migrant camps in Greece, where tens of thousands of migrants have faced restrictions on movement in recent months and have been largely excluded from the public health response for COVID-19. And the pandemic has shone a much needed spotlight on the lives of ethnic minorities and migrants living in the margins of our society, with some governments now committing to doing something about it. US data sets have highlighted that Black and African Americans have been twice more likely to die from COVID-19 compared to white Americans. And it's unclear what proportion of these people are migrants. Ethnic minorities have been overrepresented in cases and admissions. A Black American with COVID-19 was 5 times more likely to be hospitalized than a white American. In the UK, we've seen that death rates from COVID-19 were higher for Black and Asian ethnic groups compared to white ethnic groups, and death rates were higher overall this year for these groups. And really, this is the opposite of what we normally see with BAME groups, usually having lower all-cause mortality than white ethnic groups. Among cases admitted to critical care in the UK, 36% of these were from BAME groups, yet these populations make up only around 15% of the UK population. So clearly they're overrepresented in these settings. Specifically, we've seen males of Black African ethnicity having the highest rates of death, about 2.7 times higher than males of white ethnic background. Females of Black Caribbean origin have had the highest rates of death, 2 times higher than females of white ethnic backgrounds, and other nationality groups we're quite concerned about in the UK, Bangladeshi, Pakistani and Indian, also showing higher death rates. We don't routinely collect data in UK and many European health services on migrant status. In the UK, we record ethnicity, but a Public Health England and ONS analysis of deaths by country of birth has highlighted that we've seen increases in total deaths for people born in Central and Western Africa this year, 4.5 times higher in 2020 than in previous years, 2014 to 2018. Death rates 3 times higher for migrants from the Caribbean, from Southeast Asia and from the Middle East, suggesting that COVID-19 has impacted on migrants specifically. Similarly, this study here along the bottom from Sweden, published a couple of weeks ago, reports that being an immigrant from a low or middle income country predicts high risks of death from COVID-19. Recent data from Ontario in Canada has found that immigrants accounted for around 43% of all positive COVID cases in Ontario, yet immigrants themselves account for only around 25% of the Ontario population. The highest rates of positivity were in immigrants and refugees from Central and Western Africa and South America and the Caribbean. They were more likely to live in deprived neighborhoods. Cases were particularly high in refugees compared to other immigrant groups, and rates of testing were lower in immigrants and refugees who had lower levels of language. And this is really quite interesting because certainly in the UK, and several other countries, governments have been criticised at the start of the pandemic for producing all their public health messaging in the native language only. In the UK, it was left to groups like Médecins du Monde and the Red Cross to translate basic health advice into multiple languages. And there's been lots of calls for ethnic minorities and migrants to be more meaningfully included in national response plans going forward. So there's a clear pattern emerging, of course, between COVID-19 mortality and levels of deprivation in the UK and elsewhere. As this graph clearly shows, people who live in the most deprived areas of the UK were around twice more likely to die after contracting the virus in the first wave than those living in more affluent areas. And indeed, the ethnic differences that we're seeing are strongly associated with demographic and socioeconomic factors, such as place of residence and occupational exposures more than anything else. And we know that BAME groups are more likely to live in urban and deprived areas. They're more likely to have jobs that expose them to high risk. And this includes BAME groups being overrepresented in healthcare worker jobs in the US, in the UK and other European countries, but also in front-facing jobs more generally. Taxi drivers, public transport, security workers, cleaners. You know, these are groups of workers that have had to work through the pandemic. Some may have had no access to paid sick leave. Data are quite limited on ethnicity and mortality in healthcare workers, but in this small data set here from the UK's NHS at the end of April, reported that 43% of all healthcare workers who died in the UK were from ethnic minority backgrounds. And as you can see on this table, among the nurses, for example, among those that died, 71% were from Black, Asian and minority ethnic groups. And around half of this data set were migrants. And similarly, we've seen this in the Canadian data sets that I've reported earlier. A disproportionate number of positive cases among migrants were in female healthcare workers from the Philippines and Jamaica. So what we're seeing in these populations is that adverse outcomes are a result of complex interactions of socioeconomic disadvantage, influencing health status and exposure to COVID-19. And this slide presents a summary of the literature on this topic. A range of potential biological and genetic factors have been put forward, increased comorbidities such as diabetes and cardiovascular disease in BAME groups that lead to more adverse outcomes. But actually what seems to be emerging now is that it's the social and health behaviours and occupational and systemic healthcare factors that are really the biggest influence on adverse outcomes in this pandemic. The fact that ethnic minorities and migrants are more likely to live in multi-generational households, overcrowded households. In the UK, 15% of Black Africans living in housing classed as overcrowded compared to 2% of white households. Fewer possibilities to stay at home, more public transport use, barriers to accessing healthcare. We already know that there are thousands of migrants living in Europe who are not entitled to any form of healthcare other than through an emergency department. So limited access to healthcare, limited access to promotional health messaging, we've already discussed. Structural racism, stigma, lack of trust in health systems may also have had a role to play in some of the disparities that we're seeing. And these are the unexplained risks that the Institute for Public Policy Research and others this month have said driving the inequities that we're seeing in cases, admissions and deaths, independent of other factors such as comorbidities. And so going forward, better understanding these complex factors really is a critical next step to informing public health efforts. So we need to ensure that ethnic minorities and migrants are included in national response plans, improve their access to healthcare, ensure social support and sick pay, improve conditions in these camps and detention centres housing thousands of migrants across Europe and elsewhere. We need to promote research to better understand ethnic disparities in health outcomes. The lack of data specifically with respect to migrants is hampering our ability to act on what we're currently seeing. Lastly, we need to think about funding sustained and meaningful approaches to tackling some of these inequalities that we're now seeing. In the long term, this includes developing culturally competent health systems, promoting health and social rights, and universal health coverage. Thank you.